Slide, please, Sophia. Do you know what? We can move past this. The welcome and introduction part, I think, has been done. I'm going to give a brief overview of the methodology, a very brief one, just to set up the presentations by our other teammates. And then at the end, I'm going to try to tie it all together and show how business use cases get pulled into implementable specifications and what we have to do to get there. So next slide, please. All right, next slide, please. So I've given a presentation before on the IHE methodology, and the specifications that are developed using that methodology have got 4 volumes. The volume 1 is a non-engineering description. Volume 2 is where transactional behaviors are defined. Volume 3 is where content, where the payload of those transactions is defined. And volume 4 is used in IHE specifications for contextualizing a particular specification to the specific jurisdictional requirements. Next slide, please, Sophia. Oh, there we go. We're going to focus here on content that appears in volume 1. And the use case description always appears there because we always start a specification with its purpose. We describe that purpose using a story. Next slide. A story has characters and they interact with each other within a context. What's really important is that we talk about the human and the non-human or system characters, and we want to include both of these in our story. Next slide, please. The stories are always written as a narrative, so you would have characters that have names and you would say what is going on. So Mrs. Green visits Dr. Black for a diabetes checkup. Dr. Black will leverage Mrs. Green's content to provide her with patient-safe care, and he wants the most up-to-date content. So he'll fetch an on-demand patient summary from a health information exchange. And all of this is described in a narrative storytelling way. Next slide, please. Now, of course, a picture can be worth 1,000 words. So for added clarity, we could show this in a diagram, and the diagram could show as boxes or clouds the various system actors, and then with little people icons, the human actors. But then we would say, what are the beginning states? What happens in this story? And what's the end state? So here we see a sequence diagram. It's a kind of a cartoon version of what we saw in the narrative text. And Dr. Black looks up the local record in his EMR. He then leverages Mrs. Green's unique ID to fetch her patient summary from the HIE. The patient summary is built on demand, returned back to Dr. Black, and his EMR ingests it. And at the HIE side, we record an audit log that the access has happened. And the end state is that Dr. Black has the up-to-date record for Mrs. Green. Next slide, please. So just the key takeaways. Every conformance testable, implementable digital health specification begins with the user stories. These stories include the characters, and the characters interact with each other. We put in both the human and system characters, and we can leverage diagrams to show what are the interactions between the characters and what are the contexts that precede and follow those interactions. Next slide. And please, can I share now to Morten, who's going to tell us about a business use case example from Denmark.
Yes, thank you, Derek. And you can hear me?
Yes, I can.
Okay. Fine. Next slide. This webinar is about business use cases and how to develop them and use them. I have only 3 slides for today, and I'm not going into details about the use cases, but of course what I present here, we have a narrative text. We have a narrative description of the business use case. We have an interaction diagram, architecture diagram, standard specifications, and so on. But what I want to show here is more what we have been doing for many years in Denmark, and specific for sharing of care plans. So the first slide here is just to explain what is a care plan. I think we could have different opinion on and understanding what is a care plan. In a care plan, there are some information, and there can be many information. I think this slide here is universal. It is generic all over the world within healthcare. So if I take on the top here on the slide, you can see there are in a care plan a health concern. If you take in primary care and in hospitals, it is normally a diagnose. In social care, it is other classification system used. But for example, a health concern could be the patient have diabetes type 2. When you have this and go to your medical doctor and he is making a care plan, then he will set up some goals for you. He will put in some, and here it is very important, it is some individual goals. For diabetes, you can see the first HbA1c should be below 48 millimole per mole. This is the limit for when you have diabetes. He will also say your weight should be below 80 kilograms and stop smoking. And in a care plan, it is also important that the patient himself can also have own goals, walk 2 kilometers every day. And one of the key entities in a care plan is actually interventions. How can you target the goals? How can you fulfill the goals? And one intervention could be that you should have a healthy lifestyle course. I have put in here Ozempic, and I hope you know why I put in Ozempic. I think most of you will know it because Novo Nordisk is in Denmark. It is one of our golden eggs here in Denmark at the moment. And then you should also have an intervention you should visit your eye doctor 2 times yearly. Another important entity in a care plan is also observations, is that you can measure what is the blood sugar level, and here you can see it is 56. It is over the individual goal sets. The weight is also too high. It is 89 kilograms, and the patient here is also smoking 5 cigarettes per day. So the doctor can follow up and have a dialogue with the patient about his care plan. Care plan was started in Denmark in primary care for 6-7 years ago. We have a national implementation of care plans today. We have care plans for more than 300,000 patients for COPD, for diabetes type 2, and for heart diseases. So this is in daily operation. It is not so simple as shown here on this slide. It also contains a lot of evidence-based algorithms. So when you are retrieving many important information about a diabetic patient, the data are put into some algorithms and are supporting the doctor in setting up the care plan. So next slide. On this slide here, there is a lot of information. I will try to keep it short, but actually, when you are looking on this slide here, you can see that there are 4 boxes. Each of them are actually business use cases in itself. And if you take all 4 boxes, then it is the care plan business use case. So let me explain what we have here. The first one is number 1. We have in Denmark today 6 different vendors of DP EHR systems. Years ago, we had more than 20 different systems. I think we are stable about 6 vendors. Maybe it will go a little down. It was too many years ago. This development started around 25-30 years ago. I think this is the same all over the world today. If you take box number 2, then the 6 vendors have formed a new company, and they have developed a general practitioner service platform. So instead of each vendor developing their own components, there is in this general practitioner service platform a lot of functionality. One of the functionality is that there is a care plan module, including a database, which are integrated to the different vendor systems. So when the general practitioner is going into his GP system, looking up a patient, pressing a key to make a care plan, then he is actually calling some services, screens, sharing of data, and a lot of different interactions. The care plan is stored in this database you see in box 2. And what we have been doing in the last, I think, 2 years is that we have built up a new HL7 CDA standards for exchanging care plans. So in the general practitioner service platform, they have built a care plan CDA adapter and connected it to an index. And the box number 3, we have a national service platform for healthcare. It is based on IHE XDS document sharing, also with a national XDS registry. If you take the node box to the right, you can see that we have a number of document sharing already running. We have document sharing for appointments, for patient-reported outcome, for diagnosis, for care plan, for pregnancy, for telemedicine, for measurements, and so on. So this is actually one of the business use case in itself to get this up running. Today it is up on a level where it is quite easy to add new documents and new data to be shared. And here it is. Yes?
Just a 2-minute warning.
Good. To the right, you can see we have a national health portal. This national health portal, it is public owned, which means it is not commercial. We don't have any advertisement. We have doctors and health professionals putting in information here, and a lot of information from different organizations can be accessed via this national portal. And here to the right, you can see health professionals can access care plans. The citizens and their relatives can access their care plans, and other health persons. Maybe they don't have an authorization, but are working in the healthcare system. They can also access the care plans. And the next slides, which are the last one. And I think this slide here is very important, and also to address in the use case. How will you follow up? And here you can see for the care plan in primary care, we have followed this for 5-6 years now. This graph here only shows some months from 23 and up to today or last month in August 24. You can see how it is increasing. You can see that care plans will be updated. There will be made new care plans, and this graphic shows that it is actually going quite good. 220,000 care plans can be accessed today. Maybe it's not many, but you have to take into account that Denmark is a small country. We are 5.5 million inhabitants, so it is actually many care plans which already can be shared and gives a lot of valuable information cross-sector. Yes, this was my presentation.
Thank you so much. Sophia, the next slide, please. I'll invite Sylvia to give an example, a business use case example, radiology-based from Austria. Sylvia, the floor is yours.
Thank you, Derek, and please go to the next slide. I was invited to give a short talk on a business use case on radiology. And what I would like to present today is an example of radiology image exchange in context of the Austrian national health record named ELGA. And as an introduction to this radiology image exchange, I would like to present you a short summary about use cases that we face here in Austria, and I think across all over the world. at the bottom of this slide, you can find a reference to a publication, because there was done some research before radiology image exchange was introduced to ELGA. And what is presented on this slide is the results of this research that was done by a university in Austria. And within this publication, primary use cases were identified for image exchange. And this is assignment when a patient is sent to a radiologist to have some pictures, to have some images, some studies done, but these studies are needed for treatment in another location. And another primary use case is requesting images that has been acquired on other occasions. And the third primary use case is referral, when a patient is referred to another organization to be treated there. And there are secondary use cases like mammography screening. This is an important thing that happens in Austria. Preliminary reads when different doctors work together to create the report, or expert opinions that are acquired in complicated cases. Next slide, please. So this is one of these use cases I picked out of this list, and this is the business use case when images are exchanged in case of an assignment. And the user story reads like that a patient has to undergo surgery in a hospital and is requested to have a computer tomography, a CT exam before. And what the patient does then is he books this exam at an imaging center outside of the hospital. Then the patient does this CT, goes to the imaging center, does the CT study, and the imaging center creates the report. The report and this CT study are then registered in ELGA. When the patient then comes to the hospital to have surgery, the reports and the CT images are available in this health record, in this national electronic health record in ELGA. And they can be downloaded from there and can be imported to the local infrastructure in the hospital for further use. Next slide, please. So I tried to stick to the convention, how these use cases are described. So we have on the left side the imaging center, the radiologist in the imaging center, and the information system in the imaging center. I skipped this part where the patient receives the assignment in the hospital, because this is still done via paper in Austria. There are electronic solutions, but they are not the important part here in this use case. So the use case starts when the patient comes to the imaging center and he is administered there. The study is performed in the imaging center, and the radiology report is created. And both the radiology report and the radiology study are registered in the infrastructure of ELGA. And this is some sort of IHE XCAI infrastructure. On the next slide, I will give you some details about this infrastructure. On the hospital side, the administration of the patient is done quite before, when the surgery is planned. The patient is admitted to this external radiology, but the real action starts to happen when the patient comes to the hospital to undergo the surgery, because then the ELGA is queried for the reports and the study, and the document, the radiology report and the study is retrieved from this, retrieved from the infrastructure. And then the data are imported to the local infrastructure, and patient is then ready to undergo surgery. Next slide, please. To give you some details about this ELGA infrastructure, it's an XCAY infrastructure. We have more than 10 affinity domains, so it's quite a federated structure. We have very little centralized components. But we have some central services that are essential in this use case. And one is we have a central patient index. We have a central index of healthcare providers. We have centralized terminology server. Authorization is done centralized. We have a patient portal where patients may access their data. And we have a central audit trail that tracks all the access to this to the data in the infrastructure. And the local affinity domains are structured like XDS, XDSI affinity domains with registries and one or more local repositories. The link between these affinity domains is done via gateways. Next slide, please. So the key points to take away from this business use case and its implementation in Austria is that using the infrastructure, the ELGA infrastructure, in radiology use cases is a paradigm shift from a push to a pull model, and this avoids the administration of hundreds of point-to-point connections between imaging organizations. It makes the data available whenever and wherever needed for the actual case and beyond. And it enforces the out-hospital sector with the promise of more efficiency and the promise of cost reduction. And that's all from my side. Thank
Sylvia,
you.
that was wonderful, and thank you. I have a soft spot in my heart for health information exchanges, and thank you for introducing the one from Austria. Nicole.
You're welcome.
Thank you. Nicole, we go to you now with an example of an empowered patient, the patient-facing app example from the Unicom project. Nicole, the floor is yours.
Thank you, Derek. Hope that can you hear me well. So good afternoon, everyone. Next slide, please. Today, I will present to you the use case of the patient-facing app developed for the Unicom project. The Unicom project is an Horizon 2020 that has as a full name Upscaling of Global Unique Drug Identification. It started in 2019 and it ended in May 2024. So a few words just to wrap up a little bit about the project. The project helped to ensure that any drug and its content can be accurately identified anywhere in the world. So in Unicom, patient-facing apps aims to empower patient access to medical information and find substitute drugs abroad. An important purpose of this application is to provide patients with the information about the medication they are taking, put them on their personal medication list, and have a secure tool with them when they are traveling abroad to find the same or equivalent medication in a foreign country. Next slide, please. Derek? Okay, thank you. For the Unicom project, we developed two types of applications. One is dedicated to patients, and 3 different applications were developed for this scope, namely PharmaWizard for Unicom, eHealth, and InfoSage. And then we developed a second type of application that is dedicated to the healthcare providers. Next slide, please. So with the patient-facing app, the user is able to create a medication list so the patient can save medicinal product on his or her mobile phone. With the patient-facing app, the user is also able to generate a QR code for the healthcare provider app in order to communicate with the pharmacist, that is the dispenser, about the drug that needs to be substituted. And in the end, with the patient-facing app, the user is also able to add the substitute drug to the medication list in order to record the pharmacist chosen medication on the application. Next slide, please. Then with the healthcare provider app, the user is able to scan the patient-facing app generated QR code to obtain a list of similar medication and their characteristics. The provider can view the medication the patient is currently taking if the patient wants to. With the healthcare provider app, the user is also able to consult a list of potential substitute medication to select the best substitute medication for the patient, and here we have the man in the loop, and generate the QR code that needs to be sent back to the patient-facing app to inform the patient about the choice. Next slide, please. So I would like to present you our citizen. That is an Italian citizen called Mario. This Italian citizen suffered from epileptic attacks and used carbamazepine to treat this disease. So Mario, in his application, will have a medication list with carbamazepine to treat epileptic attacks. Next slide. Thank you. So let's imagine that our Italian citizen Mario wants to travel to Greece for vacation. Next slide, please. Okay, so our Italian citizen goes to Greece on holiday, but he forgets the medicine carbamazepine at home in Italy. So he absolutely must find a good substitute for his carbamazepine, his drug. He goes to the pharmacist and he uses the application. So he can view his medication list in the second screen. He can select the carbamazepine, and in the third screen, you can see that he is able to see the carbamazepine characteristics. And pressing the button, he is also able to generate a QR code that needs to be shown to the pharmacist. Next slide, please. So at this point, the pharmacist recognizes that the medicine comes from Italy. Thanks to the healthcare provider app, the dispenser can identify a similar medicine marketed in Greece and can show the patient the new drug. So in the first screen, he is able to press the button and scan the QR code sent by the patient. He is able to view the characteristic of this drug that need to be substituted. He is able to see a list of potential similar drugs, select the best one, and pressing the button generate a QR code that needs to be sent back to the patient. Next slide, please. Okay, thank you. So the Italian citizen Mario scans the pharmacist QR code in the first screen and add this drug to the medication list. So now our Italian citizen Mario has carbamazepine in his medication list, as you can see in the second and the third screen, and also in his bag. Next slide, please. So here our use case ends. And in this slide, you can see another representation of our use case using the path provided by IHE-Europe. So you are able to see our humans that are our patient Mario and the pharmacist, and non-human that are patient-facing app and healthcare provider app. So the patient need to be download the application, and also the pharmacist need to download the application. At this point, the patient saves medicinal product on his or her mobile device, like carbamazepine, for example. He is able to generate the QR code for the healthcare provider app to communicate the drug that needs to be substituted. At this point, the pharmacist with the application, with the healthcare provider application, is able to view the medication, consult a list of potential substitute medication, and at this point, select the best substitute medication for the patient. With the healthcare provider app, the pharmacist is able to generate for the patient-facing app the QR code to inform the patient about the chosen medication. And at this point, Mario is able to add the substitute drug to the medication list to record the choice. At this point, Mario or the patient has his medication list updated. So this is the end of my presentation. Thank you.
Nicole, thank you. And for those on the call, I have had the good pleasure of seeing this demonstrated live a couple of times at conferences where Unicom was presenting. And these screen captures are a wonderful summary of that. But I gotta tell you, it was super fun watching it being acted out in real time with the app being used. And you can only imagine a group of people huddled around each of the devices, seeing in real time how this very empowering software was made to work. Thank you, Nicole.
Thank you, Derek.
Okay. I'm going to turn on my camera again, and could I now draw us to a close by talking about IHE profiles and their ability to act as reusable building blocks that we can leverage to bring our user stories to life. Next slide, please, Sophia. So how do we go from stories to specifications? Next slide. I'm going to use an example from my co-home country. I spend half my time in Canada, half my time in France these days, but this is an example from Canada Health Infoway. And the problem they were addressing is how do we build an on-demand patient summary? And that was one of the steps of the use case that I was showing earlier. Next slide, please. So domestically, Canada adopted the IHE methodology and developed a 4-phase model as its process for coming up with digital health specifications. Next slide, please. So the first phase is to do the use case descriptions, the clinical or business description. Next slide, please. The second phase is to disassemble this into its workflow components. Next, please. Third, we map this disassembled set of workflow components to interoperability standards and look for Lego blocks that might be already in the toy box. Next slide, please. Of course, we want to assemble our Lego blocks, and so we would create an implementable architecture from the Lego blocks we have. By the way, step 3 would also surface where there was a Lego block we needed. Next slide, please. Let's go forward again. So the example we're going to use is building an on-demand patient summary. Next, please. And to be blunt, this was exactly one of the use cases that was developed by Canada Health Infoway as part of its work towards a national patient summary infrastructure that could be leveraged from jurisdiction to jurisdiction and within jurisdictions to support care continuity. Next slide. Okay, to do an on-demand patient summary, we need to be able to do 4 things. We have to identify who is the patient. We have to get permission to access the data sources that hold information about this patient. We have to use the permission we've got to fetch the data. And then lastly, we need to assemble this received data into a well-formed patient summary that meets the content requirements that Canada has defined. By the way, Canada has adopted the International Patient Summary as the heart of this initiative. Next slide, please. So just a quick bit of refresher for folks that might not have seen other of the IHE-Europe webinars. At the heart of the engineering approach for IHE is the notion of an actor-transaction pair. So actor A and actor B will have some transaction that they do between each other, and these are named using the domain committee plus the next number in the list. So IT infrastructure committee would have ITI1, ITI2, etc. Patient care coordination would have PCC1, PCC2, and so on. Next slide, please. Why did I tell you this? Because to do the unambiguous identification of the patient, we would have 2 actors, patient demographic consumer and patient identity registry, and they would do the transaction mobile patient demographics query, which is from the IT infrastructure committee, and it happened to be the 78th transaction that they had defined, ITI 78. Next, please. To get permission, we would use the authorization client and authorization server, and you would get an OAuth token, ITI 71. Next, please. Now here we introduce something called grouping. So an authorization client would be grouped with a document consumer. The resource server would be grouped with a document responder, and we would use ITI 67 and ITI 68 to find and retrieve documents. This is how we would retrieve CDA information to be pulled into the patient summary. Next slide, please. Of course, we could group with a clinical data consumer and a clinical data responder and use PCC44 to fetch FHIR-based information that we want to include in the patient summary. Next slide, please. What we found when we were doing our work in Canada is that there wasn't already a Lego block that would now collect this into a PSCA, which is the Patient Summary Canadian version. And so that was the one Lego block that we had to define, and we had an expectation that we would be creating a new Canadian transaction, CAN01, to do that. Next slide, please. Now, a patient summary assembler or a builder would have to do all of these transactions. Please, next slide, Sophia. So the builder, next slide, would be grouped with the clinical data consumer, next slide, and grouped with a document consumer, next slide, and the authorization client, next please, and the patient demographics consumer. And so a digital health solution that would do this building would have to be able to be grouped with these 5 Lego blocks together. Of course, these 5 Lego blocks communicate with other services. Next slide, please. Importantly, when we want to be able to test our implementable architecture at a Connectathon, we would have to have 5 entities. 1, the 5 Lego block patient summary builder. 2, a patient identity registry. 3, an authorization server. 4, a grouped resource server and document responder that could serve up CDA documents. And 5, a resource server and clinical data source that could serve up FHIR content. Next slide, please. So the key takeaway here is that user stories are absolutely foundational. They describe what the specification has to do. And then we feed the downstream processes. We map these to workflow steps. We in turn map the workflow steps to building blocks that we either have or that we need. And then we show how these can be assembled into conformance testable reference architectures. And that's what we test at IHE Connectathons. And I hope we have left ourselves, yes, we have. We've left ourselves time for questions. And next slide, please. Oh, I did have a little note, point that I wanted to make. Of course, where it is practical to do it, we will maximize the implementability of our user stories when we define our user stories in terms of the building blocks that we already have, in terms of the Lego blocks that are already in our toy box. And that is a really important aspect of the contributions that we as health informatics professionals make when we are advising the clinicians, the hospital groups, the jurisdictions that are establishing their business use cases. It is a benefit that we can afford to those teammates by helping them appreciate, listen, these are the Lego blocks we have, and where we can define our user stories in terms of those, we can quickly go to scale. And that's an important aspect, I think, for us all. Next slide. Okay. Thank you from all of us. Please, could I ask all of the presenters to turn on their microphones? And can our call administrators please leverage the Q&A or the chat to help manage the Q&A portion of today's session?
Thank you, Derek, Nicole, Morten, and Sylvia. Very interesting stories. We do have some questions in the chat from Maurice and Jan. Feel free to unmute yourself and speak up. It would be interested, or I would be interested in understanding, knowing that IHE supported standards that were used for the UNICOM project. Can Nicole or Sophia reply to that question?
Or me. I was also I was teammates with Nicole and Sophia as well, but please, Nicole?
Yeah, only just want to say that in UNICOM we have developed a test lab in which this demonstration of the patient-facing app were done using the action transaction framework that Derek explained to us. So Derek, if you want to add something, feel free.
I can add that the patient-facing app especially made use of fire resources, and our Unicom teammates were very active with HL7 in evolving the fire resources to adopt IDMP. And the IDMP is the family of ISO standards that Unicom was leveraging to give this unambiguous coding definition so that medicines across borders can be identified. And the sets of resources that were used by the patient-facing app included the medication resource. I think the medication statement might have been used, and possibly medication order, because of course, when a new prescription is being created, that would be the resource leveraged there. So the PFA, the patient-facing app, leveraged the fire-based resources. Because Unicom is something that was being implemented across Europe and there's such strong adoption of CDA, there is also testing that was done related to the CDA-based pan-European specifications for how documents that contain these this medication information was used. I'm sorry, I stumbled over myself trying to answer that second part, but those were the specifications that were leveraged in Unicom, and there is a full publication of those specifications.
Maurice, please speak up if you have an additional question on this, or was the answer satisfying?
Yes, no, this is Maurice speaking. Thank you for your explanation. No, it's satisfying. I was wondering, which standards were being used, and as I understand it, it's primarily based on fire and also CDA. Okay, thank you.
We have another question from Jan. When you write a specification in a country that has IHE-based infrastructure, you take a lot of the functionalities for granted and concentrate on your business objective. How do you do it in a situation when you do not have IHE-based environment and have to solve tasks that could have been avoided, or vice versa? We know all about it, Jan, because I live in Belgium and we don't have an IHE-based environment. Derek, can you shed some light on this situation?
A little bit, and I can share that I do a lot of work and have for the last 15 years or so in low and middle income countries, which are very much a greenfield sort of an approach. I guess one of the things I'd like to highlight, and then I'll call on my teammates to chime in here, but one of the things I'd like to highlight is we tend to use a CDA infrastructure. We use the moniker IHE to say that's an IHE infrastructure. To be blunt, that's an HL7 CDA-based infrastructure. IHE profiles underlying standards and describes how a portfolio of standards will be used to address a use case. There are 4 or 5 dozen fire-based IHE profiles, and there's dozens of CDA-based IHE profiles. I say that because even in low and middle income countries, they are leveraging IHE profiles of fire if they get to start with a green field, but they're still looking for conformance testable, implementable specifications. And to get to the ability to go to scale, you have to, as I like to say, take all the fun out of it. So you can be standards-based without being interoperable. The key in IHE is to say, how will we leverage standards to be interoperable so that we can go to scale? And I know that both Sylvia and Morten can speak of the ways that standards have been leveraged to go to scale and the way that those standards have been profiled by IHE, so you can do conformance testing and you can actually implement digital health solutions that click together like Lego blocks. Maybe Sylvia, I'll ask you first to comment on how that's been done in Elga, and then Morten, please, the Denmark example after that.
Thank you. For Austria, the main thing that happened was that there was a political decision to have this central national electronic health record. It was a very long process to establish this and to have the legals done before, but finally it was a political decision to have this infrastructure up and ready. And from the first minute, it was clear that it would be standard-based and it would be IHE-based. And at this point, it's just up to me to say thank you for IHE for all the work that was done before we started with our implementations in Austria. So there was the legal basis to have this central infrastructure. The problems then when it comes to connect systems to this infrastructure, and especially elder systems that are not on this point of implementation, not as interoperable as expected. And this is where it comes to find solutions using gateways or things like that. This is what we face in Austria. But what we have, and I'm very happy about this, is that we have this IHE-based infrastructure. And standards are really important, and I think for future more important, especially when we look to the initiatives in Europe. Everything is about interoperability, not only in countries, but across whole Europe.
Thank you, Sylvia. Morten, please.
Yes, I think from the user stories, the standards are the key, and it should be mature standard, documented with test protocols and everything. In Denmark, we have today at least 150 different standards within healthcare. That's a lot of test protocols and a hard work to test the systems. And as I understand Jan's question, if you don't have an IHE infrastructure or environment, what then? Actually, we have been in that situation for many years in Denmark. With the 150 standards, only a small group of them are based on IHE and HL7 and CDAs and FHIRs. Most of our standards in Denmark for healthcare are actually UN EDIFACTs. Maybe some of you will know it. It's very difficult to read. They are very difficult to develop. The testing is more or less the same if it is CDA, FHIR, or EDIFACT. We are slowly shifting to IHE infrastructure. You saw on my presentation IHE XDS. I don't know how it will be in 5 or 10 years. Maybe it will shift also when you have other technologies. But I think our focus and our leading strategy is that it is really important that you have mature specifications out there. So we are going international today and say, where do they actually have been doing what we want to do? And then we are making Danish profiles and putting it into daily operation. Unfortunately, sometimes we can't find it international, and then we are starting from scratch, and it takes many, many years to get from an idea to a business use case where a new standard. It looks simple. It is simple in the business use case, but until it is fully implemented and tested in all systems, it is a huge work to do. Yeah. So I will say it is quite good if you can go and say, okay, we want to be IHE compliant, then there are a number of components and standards which are taken for given. This is what you're saying, Jan. But if you don't have this, then I think you have another concept where you also have other building blocks which are given for you.
I like to draw on that because Morten, it does de-risk things for any one of our countries, any one of our member states to be able to leverage building blocks, because our problems are very rarely idiosyncratic or strange. It's usually all of our European partners have got the same challenges that we have, and by banding together, we can address common challenges. It's one of the things that I think IHE-Europe provides as a useful contribution, is a forum and a methodology that's quite mature for us to surface these and to address them. I'd like to call through something, I'd like to ask Nicole to call to something about the use of specifications with the patient-facing app, and also the idea that what if something new had to be done? And Nicole, you were able to leverage a bunch of sort of building blocks that were there, but finding a substitute medication required some net new work to be done by the teammates to see how we could use IDMP to say, well, what are the things that are functionally the same, but are actually different products? And there was a question about, did you need to make any adaptations to IHE profiles? That required some net new development on your team's behalf. And just a couple of minutes, please, because then we have to close. Maybe 1 minute, sorry.
In the patient-facing app, we leverage on different package. Let's say we have the first one that is the IDMP database that was developed by that wizard, and also there is the smart substitution component that was developed by Gnomon. In fact, one of the patient-facing apps that were developed is the EL Pass developed by Gnomon. So it's a matching of different skills to build this use case, I think. Don't know if I get the question well. If not, please, Derek.
No, that was what I was looking for. The idea that this matching algorithm had to be developed, and there wasn't one yet. And so leveraging the existing Lego blocks we had, we were able to add some new functionality. And my recollection is that was supported as a service that could be leveraged centrally by any of the patient-facing apps. That was a database query that could then be returned.
Yes, yeah. And the difficulty is highlighted by the fact that we had the pilot only by 3 different countries and no more, because it's very difficult to create the IDMP standards for all the countries. So maybe further.
Thank you very much, Nicole. I'll let the call administrators close our call. And thank you, please, thank you so much to the other presenters. What useful information. Thank you all. Over to you, Sophia.
Thank you very much, Derek, Nicole, Morten, and Sylvia. I think it was a really interesting presentation. As what mentioned in the chat, you will be able to, the slide will be sent to you, and you will be able to see the recording soon on YouTube channel. So just one quick thing before we leave, we will have our next webinar. It will be on the 11th or 18th of October. It will be on the IHE domain and the focus on the radiology domain. So we will send the registration link soon. So thank you again very much for the question and for the presentation, and we hope to see you soon in the next edition. Thank you very much.